Welcome back, Rebel EM listeners, to another episode of Rebel Crit. I'm your host, Frank Lodeserto, and I'm joined by my co-host and our chief resident,
Dr. Eric Acker.
Eric. So last time, tell us what we talked about.
Yeah, so we talked about the different ways on ventilators we are able to achieve giving patients breaths. So we have a few different mechanisms. We have the controlled breath, where the machine is doing basically all the work. They are providing the volume or pressure, which we'll get into in a second here. Then we have the assisted breath, where the patient might be providing a little bit of effort. They might be moving the diaphragm a little bit, and then the machine is taking over and providing the rest of the breath. Then we have the supported breath, where it's not quite the patient on their own, but the patient is initiating the breath, is performing a lot of the effort, and the machine is providing the little extra support to get them all the way to the end. And then the delivery mechanism, as I mentioned before, we have volume, where we can set the machine to deliver a certain volume over a certain period of time in a minute at a frequency, which is your respiratory rate. And then you have your pressure settings as well. You can also set up machine to deliver a set pressure. So that's about where we left off.
And if you hadn't listened to the last episode and you're just joining us for this one, you might want to go back to listen. That was just a quick summary wrap up from Dr. Acker. Today, we're going to talk about modes. Now, I talked about last episode how I was very confused. The first way I learned about ventilators was just telling me about modes, and I didn't understand much. But now understanding the types of breaths and how those breaths are delivered, I said in the last episode, you can pretty much figure out almost every ventilator mode there is. And I'll give you a few examples of common modes that we use.
Are you sure we don't just put a person on the one good mode and then these other ones are just for whatever?
I'll say, Eric, some people just have one mode, unfortunately.
PRVC, right?
At some institutions, PRVC is commonly used. Sometimes it's called autoflow. There's different names for these ventilators. It's like alphabet soup. But I think, too, what I learned as a fellow back at Children's Hospital of Pittsburgh, actually, was that ventilator modes are really for comfort of your patient. And if you know a lot of modes and you can change the modes to make your patient comfortable, then you're doing a lot of good for your patient. Because we've seen that no mode is really better than another. So any mode that you can use that works is great. But I like to know all the modes because I think that's where all the patient comfort can come in. If you can find the right mode for your patient, then you can make your patient comfortable. So modes are very important. But again, no single mode has really shown any mortality or morbidity improvements over another mode. So again, if you just know a couple of these modes, that's fine. But knowing more modes and how they interact with the patient can really allow patient comfort, which is the key to all this. But let's start out with a couple common modes. One of the most common modes that we see is something people refer to as volume control. They'll say patient is on volume control. It's a little bit of a misnomer because really what they're on is assist control volume. And in that name, assist control, basically tells you can take two types of breaths, assist breath or a control breath. And when that breath is being delivered, it's going to be a set tidal volume. So everything's in the name right there. Assist control volume, or people refer to this as volume control. So Eric, let's just go through this typical mode. They're almost getting into setup a little bit, but I do want to defer that to a later talk when we talk about the types of physiology we're setting up the ventilator for. But if I put you on an assist control mode, particularly volume, now the same would go true of pressure. I can be assist control pressure, only difference set tidal volume, which is the assist control volume. In a pressure mode, you're setting a set pressure, a pressure control. So again, two types of breaths here. If I were to set the ventilator rate at 10, that means if my patient is paralyzed, sedated, or has got some severe brain injury where they're not triggering the vent, then how many breaths would they get a minute if they're not triggering it, if I have you on a rate of 10?
So that's 10 breaths per minute, right?
10 breaths, yeah. I'm not,
It's like
I don't want to.
math I got to do.
Yeah, try not to trick Eric here. So every 6 seconds, they get a breath. Now, let's say your patient does start waking up from maybe it was a paralytic you gave him for the intubation, and they start breathing 20, 30 times a minute here. What will the majority, if not all of those breaths be now that they're breathing way past the set rate of 10? What types of breaths would they be?
So that kind of breath would be an assisted breath.
That's right. So now they're triggering the ventilators. Again, in assist control volume mode, or volume control people refer to it as, they can only take two types of breaths. assist or controlled. They're not really getting controlled unless a few things. They're paralyzed, overly sedated, maybe they're brain dead, and they're not triggering breaths at all or have a severe brain injury, and they're just not triggering it. Then those will all kick in. Every 6 seconds, they'll get a breath with a rate of 10, and they'll get a control breath. Or if you set the rate extremely high and it's just triggering breaths, a rate of 30, so every 2 seconds a breath's coming, those would be controlled breaths. But if the rate is low enough and the patient's awake, they're going to be triggering the ventilator and they're going to get that set tidal volume, and those are going to be assist breaths. So pretty easy. You can imagine the same thing for a pressure mode. Instead of getting a volume here, they're going to get a pressure. And then if they get a pressure, what do you want to know on the ventilator?
The tidal volume.
Absolutely. And that's going to be related to the compliance of the patient's lung. And I don't think I mentioned last time, compliance is the change in volume over a given change in pressure. If the tidal volume is set at 500, but it's taking more and more and more pressure to get that same volume, then your compliance is decreasing. We alluded to that last time. That pretty much covers assist control volume and assist control pressure. Let's talk about a relatively easy one here, pressure support. And we mentioned last time the pull-up analogy, and we talked about Eric's quest for a pull-up. Maybe he can, maybe he cannot do one. But again, this is going back to the banded pull-ups here, Eric.
This is the pressure support. So these are the patients who are going to make the effort. Machine is going to deliver a pressure. We're going to make some adjustments to how much pressure is to try to achieve a goal tidal volume. But essentially, it's mostly just driven by the patient's effort.
Absolutely. There's no set rate here. Now, there is a safety mode. We'll get into some of these sort of nuances later. There is a safety mode if your patient is not triggering at all and is apneic. You can set a safe apnea time. You can make it 20 seconds. You can make it less, make it longer. So if the ventilator does not see the patient triggering a breath here, then it will kick into a more assist controlled mode and deliver a breath, whether that's pressure or volume. But in a pressure support mode, it's just like the banded pull-up. Patient is triggering it, and depending on how much pressure they have, that was analogous to the thickness of the band. So I can give them a lot of pressure and they do very little or no work. I just make that the fat band in the gym. If you ever see someone in a gym shooting up and down on the pull-up bar, they're essentially not doing anything. The band's too thick and it's shooting them up and down the bar, and they're doing very little work besides triggering it. Or I can make the band very thin, and then the patient's doing a lot of work on their own, but the band is giving them some support. That's a lot like what a pressure support breath really is.
And I know in our ICU, we often see this as that last stage where testing out whether this patient's going to do well on extubation.
Absolutely. Yeah. So a lot of the trials done for readiness for extubation were done with using pressure support or CPAP, and we typically like them on a low pressure support before we extubate. Every patient might be different, every intensivist may be different, but at least some of the guidance from the literature say at least pressure support of 5, which would be a thin band. And if they can take a pretty significant breath with that, with not too high a rate, then they're ready to be liberated or extubated from the ventilator. So that's the pressure support. And you mentioned something, Eric, a mode called PRVC, pressure regulated volume control. And that, at least at our shop, we see a lot of patients set up on that mode.
Tell me more about this PRVC.
Sure. PRVC, so it's pressure regulated volume control. Basically, this is a bit of a misconception. A lot of people think it's more like a volume mode because there is a set volume, but we haven't got into like flow patterns or flow. There's generally 2 types of flows. There's a pressure flow, which is a decelerating waveform, which is very similar to how we physiologically breathe. We breathe by a decelerating waveform. And then there's a square waveform, which again is not how we physiologically breathe, but this is seen mostly in volume modes. So if you look at the ventilator, if someone's on PRVC, it's a decelerating wave flow. So it's actually very similar to a pressure mode because the flow. So what it does here is it basically gives them the lowest pressure to target a tidal volume. So again, we in medicine like to be in control of things. We like to set the rate and we like to set the tidal volume because those 2 things combined make up the minute ventilation. So we can be in complete control of the tidal volume, the respiratory rate. So here we know we can guarantee them at least a certain volume. And this is a decelerating waveform, very similar to how we physiologically breathe. So we give them the benefits of pressure, which is physiologic. There's comfort because it's a decelerating waveform, but also be in control with the set tidal volumes. So it combines some of the benefit of pressure and the benefits of volume together in one breath. Now, there's some downside to using PRVC, especially, and there's some safety features as well. So one of the safety features, it was set up to prevent patients from getting barotrauma. So we can set up a safety feature saying set the pressure limit, the pressure alarm limit to be 35. We don't want that pressure to go higher than 35. And if it does get to 35 or above, they will get no more pressure, and therefore whatever volume they get will be what they get. So I'll give you an example. So it'll start alarming 5 centimeters of water pressure before the alarms comes on. So at about 30, it'll start alarming. And it'll say, hey, we're getting dangerously close to that 35, that if the pressure gets too high, and then it'll stop delivering more pressure, and whatever volume you get at that point. So that's a safety feature. It was set up to prevent barotrauma. It was also set up to give them that flow pattern of pressure, but also deliver a set tidal volume, which again, we'd like to be in control of the respiratory rate tidal volume because that's our minute ventilation. One of the other problems with it, if we have an agitated patient, so they're tachypnic, they're working hard on the ventilator, something we try to prevent actually by intubating them. They were working too hard to breathe, maybe that was one of the reasons we intubated them. We don't want them working so hard. So we put in a breathing tube, we try to sedate them, but they're awake, they're fighting the ventilator, they're taking breaths, they look uncomfortable. PRVC is set to give you the tidal volume at the lowest pressure. But if the patient's working hard, it can't sense that. So if they're tachypnic, agitated, working really hard to breathe, the ventilator may say, look how good Mr. Johnson's doing. They can't see Mr. Johnson the way we see Mr. Johnson. Mr. Johnson's working really hard to breathe. The ventilator says, look at this. Mr. Johnson is doing so good. I'm going to take back some of the pressure because he doesn't need it. He's doing a lot on his own. However, we see a very tachypnic, agitated patient. So I can either change the mode, I can either sedate Mr. Johnson. So I have some things that I can do here, but that might not be the right mode for Mr. Johnson. Maybe I want to give them a set pressure to get them the volume they want, or maybe I have to change the mode. Maybe it needs to be a spontaneous mode, especially if Mr. Johnson's awake. So PRVC is a good default mode, very much similar in the terms of flow pattern to a pressure mode, which again, many people think of it as a volume mode. It is a pressure mode because the flow pattern is like pressure, but again, may not be the best, especially if you're hitting these high peak pressures, dropping the volumes, or if a patient is very agitated and fighting the ventilator, it may give them less and less pressure because it senses the patient's doing well when unfortunately they're not. So that's PRVC. So we've covered a lot here. We covered assist control volume. We said that if you know assist control volume, then you know assist control pressure. We covered PRVC, and I'll add some more things into the show notes about PRVC as well. This is meant to mostly give you an overview. And we also talked about pressure support. And I'm not sure how we're doing on time, Eric. There's one more mode that we don't use very commonly in adults, but I use all the time as a pediatric intensivist. It's called SIMV.
I was going to say, I see this on the notes here. I have never used this.
And we commonly use this in pediatrics and pediatric ICUs all over the country, depending on which unit you're in. And I remember as a fellow asking one of the first pediatric intensivists, why in pediatrics do we use SIMV? And when I'm on the adult side, we don't use SIMV. And I thought I was going to get a real physiologic answer about how kids and adults differ. And the pediatric intensivist looked at me and said, because the adults don't know what they're doing. And then she walked away. And I said, okay. I do like SIMV. I know that some of the data that came out for it originally was not favorable, at least on the adult side. So I'll talk a little bit about how it works, but they try to use SIMV as a weaning mode. I'll explain how it works. Basically, you take a set mode like assist control volume or assist control pressure or even a PRVC, and you add the ability to take pressure support breaths on it, essentially. All right, it's called synchronized intermittent mandatory ventilation. It adds the ability to take pressure support breaths. So what they would do is put you on a higher rate, wean the rate, and essentially you'd be on pressure support. And they found that to take longer weaning a patient and took longer to get the patient liberated from mechanical vent support than just going to a spontaneous breathing trial each day. So that was one reason it fell out of favor. The other reason is that the pressure support breaths need to match the assist or control breaths, usually assist breaths. I'll explain in a minute. And if they don't match, then the patient can get very dysynchronous on the ventilator and uncomfortable. You can adjust the pressure support breaths to make them at least 2/3 of the assist breaths and make the patient comfortable. So there are ways, if you like using SIMV, to use SIMV. And actually, I do use SIMV. And I explain to my therapist why I'm using it, what I'm using it for. So as long as you have a good discussion with your therapist. But again, I recognize as a pediatric intensivist, also working in the adult ICU, this is not a common mode for most adult intensivists. And some of you guys listening to this will say, no, we would never use that mode. And that's fine. I'll just explain it here. Whether you decide to use it one day or not, that's really up to you and if your patient needs it. But let me go ahead and just quickly explain it because it is a bit confusing. And I'm assuming that my co-host Eric probably hasn't seen this before because we don't really use it a lot. So you would have to choose a primary mode. So let's say in this case, we'll choose assist control pressure as our primary mode. Now I add SIMV, which gives you the ability to take pressure supported breaths. Okay. So let's say on this assist control mode, SIMV pressure support, I set the rate at 10. Okay. So every 6 seconds, the patient will get a controlled breath or assisted breath. So similar to just straight assist control pressure. The only difference here is in between those 6 seconds, if the patient triggers a breath, if they were just on assist control pressure, that breath that the patient triggered would be an assist breath. Here on SIMV mode, if they trigger a breath, the rate is 10. So if they trigger a breath in between that 6 seconds, instead of getting an assist breath on SIMV pressure support, they will get a pressure supported breath. That's the big difference here. So let's just say they're on pressure control SIMV with pressure support. I set the rate at 10. The ventilator will give them 10 assisted or controlled breaths. If the patient's paralyzed, overly sedated, they're only going to get controlled breaths at a rate of 10, and that is it. But let's say our patient is awake, alert, triggering the ventilator. Then basically every 6 seconds, they'll get a breath, and that breath will be probably triggered by the patient. That'll be an assist breath. Now my patient, though, let's say he's breathing or she's breathing 20 times a minute. In between those 6 seconds, when the patient triggers a breath, it's not going to be an assist breath now. Now it's going to be a pressure-supported breath. That's the big difference. So they can take assist breaths or pressure-supported breaths. Now, the big thing is that I need to make sure that I add enough pressure support to get close to that assisted breath. So if I had them on a pressure control mode, and let's say the pressure control here was 15, and that was giving them like 400 cc's, let's say. So I want to make sure I at least have something close to that. I'd be choosing a pressure support of around 10 to 12, maybe not as much as 15 because they wouldn't be doing much work. So 10 to 12, have the patient doing a little bit of work in between. There's some comfort to that to get a breath very similar to 400. Maybe it's in the 350, 380 range. Maybe it is get close to 400. That's really the only difference. You might say, why in the world would you use that breath? Well, I do think that the ability to take spontaneous or supported breaths, and this is my philosophy on it, is much more comfortable. When I can get a patient to breathe spontaneous and put them on pressure support, or there's another mode called volume support, I'm going to take that opportunity to do that because I think the patient is doing more work on their own, more effort on their own. That will help decrease the amount of atrophy they get in their diaphragms and muscle strength. It'll decrease the amount of muscle loss they're having, and they'll get them to do some work on their own and keeping their respiratory muscle strength up. So if I have the ability to put them on an SIMV mode and they're tolerating it, and I have that backup rate, so to speak now, so rate of 10. Now, most of their breaths, if they're breathing 20, 30 times a minute, which is a high rate, by the way, but if they are doing that, they're going to be pressure-supported breaths. I'm not using this as a weaning mode. I'm using it as primary mode because I want my patients to take some pressure support breaths. I would love to just switch them over to a pressure support mode, but sometimes some of my therapists don't like them just being primarily on pressure support. So sometimes I'll play the game of putting them on SIMV just so they can get these pressure supported breaths. But I have a discussion with my therapist. I'm very respectful to my therapists and I want them to feel comfortable because they're going to be managing the vent. Oftentimes, if I have to leave the unit for a cardiac arrest or go somewhere else around the hospital or see another patient, I want them to know what my strategy is on the ventilator, why I'm doing what I'm doing on the ventilator with the mode. So we're on the same team taking care for the patient. All right. So that was a long-winded explanation. We've covered a lot here, Eric, and probably should stop this because I think our listener's brain may be exploding. If it's not and you understand this and it was a nice review, I'm happy. If this is somewhat new to you, these modes are new to you, that's okay. Take another listen to this. Hopefully these become second nature to you if you're using the ventilator a lot. So we talked about assist control volume and essentially assist control pressure. We talked about pressure support. We talked about PRVC, and then we did add SIMV in there as well to give you a pretty comprehensive overview of modes. Now there's other modes. We haven't talked about APRV. I have another talk on APRV on Rebel EM that you can go listen to. There is a newer mode called volume support, which is basically essentially a mode like pressure support. Although, again, it's like PRVC. I want a set volume, and this is a spontaneous mode. And if you can imagine, this will auto adjust the pressure to give you the volume you want. So if you're in the gym doing a pull-up, this will auto adjust the thickness of the band to give you the pull-up that you need. So if you need more strength to get that pull-up, then you'll get more pressure to get the volume you want. If your patient has pretty good strength, this will give you less pressure to get the volume you want. So it's basically the spontaneous mode of PRVC. That's called volume support. So let's end there, Eric. We covered in the first talk the breaths, the way the breaths are delivered. We've talked about modes, and I think it's a good stopping point before we talk about some other things. What do you think, Eric?
This is a great stopping point.
Thank you, Rebel EM listeners. We will see you next time for another episode of Rebel Crit.